eval on the elbow. So just to start off with, to get the general history, you will first need to determine whether the pathology is acute or chronic. If it is an acute pathology, then you need to find the mechanism of injury, what causes the pain, what alleviates the pain. For chronic, you will need to find out how persistent the pain has been, how long it's been there, what activities cause the pain, what activities alleviate the pain. For observation of the elbow, you can first by noting if there be any gross deformity present or any discoloration. If you could stand for me, please. Also, you would need to look at the carry angle. You would have your patient stand in an anatomical position. Just note this for me. And note whether they have cubital varus or cubital valgus. He looks pretty normal for a male. Normal range is within 5 to 10 degrees. Another, if you could turn out for me. Another thing you would need to note for palpation on the elbow, you could locate the isosceles triangle. I'm not going to draw on it, I'm just going to show it. But you would note by finding the medial epicondyle, drawing a line to the olecranon process. You would then locate the lateral epicondyle, draw a line there, and then connect the lateral and medial condyle. That should be congruent on both sides. If it is not, then that's some type of structural pathology present. You can go ahead and sit back down for me. So for palpations, for 2 bony palpations, you could palpate the olecranon process in the posterior aspect of the elbow, or the lateral epicondyle, which is in the lateral aspect of the elbow. For soft tissue, you could locate the brachioradialis. You would just do that by palpating the radial head. It is right there on top of it. Another soft tissue palpation would be you could find the UCL, ulnar collateral nerve. That is just right in between the medial epicondyle and the olecranon process. For manual muscle tests, we will be specifically doing elbow flexion. So to begin with, you always want to have your patient, if you could have it move it as far as they can, or passive range of motion. So if you would just as far as they could go, you would then want them just to relax and perform passive range of motion, move it as far as you could. You want to note if there's any difference between the two. And then lastly, you would want to perform resisted range of motion. You would just apply resistance distally and have the patient flex their elbow again. For range of motion, if you would lie on the table supine for me. To measure elbow flexion and extension, you will have your patient lie supine. So for elbow flexion, you will place your goniometer, the fulcrum at the lateral epicondyle, and your stationary arm will be up towards the head of the humerus. You'll then have your patient actively flex the elbow. And then you will just make sure that your arm is lined up again with the lateral epicondyle and the radial styloid process. Normal range of motion here is within 145 to 155 degrees. You would want to do this bilaterally to note any differences between the two. For extension, you will take a bolster and you will place it underneath the posterior aspect of the elbow. You will again use the lateral epicondyle as your focal point, and this should be 0 degrees. If they go past 0 degrees in the negative direction, that is indicative of cubital recurvatum. For supination and pronation, if you could just sit up and hang everybody. To make this easier, you could have your patient hold a pin in their hand. You would then take a goniometer and you would line it up with their 3rd digit, also with the pin. You would have them actively pronate for me. So you would have them actively pronate. Pronation is within normal limits would be 90 degrees. He's a little bit off, but and now supinate. To make sure, sometimes their measurements may be off, but if they're even bilaterally, then no pathology is present. So for supination, again, you'll just have them do the same thing, but you'll have them supinate, obviously. Normal range of motion here would be 90 degrees. Again, if it may not be within normal limits, but as long as it's within both about the same bilaterally, your patient is fine. So for my special tissue assessments, I'll begin by performing the valgus stress test. You'll just have your patient relax, grasp this posterior aspect of the elbow and apply a valgus force. Any pain or laxity specifically radiating pain down the medial aspect of the elbow, is possible ulnar collateral ligament pathology. If there's laxity, you would want to perform that bilaterally to note if it's just in that one particular structure or if it's on both sides. For the varus stress test, you would again place your hand in the posterior aspect of the elbow and apply a varus force. If there's any laxity, this is possible RCL pathology. For resisted tennis elbow test, if you would just start here for me. So for resisted tennis elbow test, you're going to locate the third digit of your patient. You're then going to apply resistance and tell them to try to extend their finger. If any pain is noted here, that is indicative of a possible lateral epicondylitis pathology. And then for my fourth and final test, I'll be performing the Tenelsign test. So what you'll do is you'll locate the medial epicondyle and the olecranon process. Just in between there is where your ulnar nerve runs. To perform this test, just simply tap between that area. If any radiating pain is noted, that is possible ulnar nerve pathology.